Done and dusted. Okay. Cool. Okay, these are the different congenital heart disease markers. So to pass out in a good shape, at least minimum you should know this. Apart from that, you have multiple other disorders. You have to know everything about achondroplasia, how to manage short stature. This is for pediatrics. How to manage short stature. What is achondroplasia? Different types of rhizomelia and mesomelia. These are for pediatrics. And Vactal association. Many other congenital heart diseases are there. I mean, congenital syndromes are there. So other fetal hydantoin, warfarin syndromes and all. So if you know all these other things, this is excess. But this is least minimum to know, at least to pass out in a very good manner. Okay, you can nicely pass out easily. Okay, it's done and dusted. Okay, now going to the other parts of the examination. I think what is your case? I think this is the longest ever case discussion, I think, of a single case. Come on, I need to finish faster. Within this session, I need to finish BP, JVP and all. Come on. Yeah. Pulse. Okay, let us go to the case. Pulse rate is 72 beats per minute. Regular. You told finally the patient is having AF yesterday? Okay, regular. Okay. Normal? Okay, volume is okay. Rhythm? Regular. Volume normal. Okay. Then? No specific character. That is wrong. Normal in character. I don't know what they will teach you in your this thing. So you should not say no specific character, because normal pulse has a character. What is that character called? What is the normal pulse character? Normal pulse is catacrotic in nature. You would have studied, no? Anacrotic, dyspherians, that are abnormal characters. But normal pulse is catacrotic. That's why you should not say no specific character. So why you want, if you are very sure about this, you can say normal character. If they ask you, how will you say normal character? You say catacrotic. Then you can get an applause. Okay, then what else? Okay, no radio-radial and radiofemoral delay. Pardon? All peripheral pulses are felt equally. Okay, fine. So this is your findings. Let us come back to that later on at the end of the diagnosis. Then what else? Blood pressure? 100? 100/70. Measured in left and in supine position. Only one limb you measured. Okay, then see, you told you measured only in one upper limb. Then you are saying that there is no difference in BP between all the four limbs. Okay, then respiratory rate? (22 per minute). Okay. Temperature? 99. Okay, measured in the morning or evening? Morning. Okay. Then JVP? I mean, JVP again, once again, it should not come in the vitals. It should be an inspection finding only. Be very clear about that. JVP? Mic is ready. 1 second. Please keep the mic closer. JVP is not raised. So not raised means what? There is no JVP. JVP is normal. So what is normal JVP? Huh? What is the height of JVP? Below 9 is considered normal, I know. But what is your patient's JVP? You didn't measure it all. You're saying 8 centimeter. Okay. So your patient's JVP. What is your patient's JVP? 8 centimeter. Is there any abnormal waves? No abnormals. Everything is normal. Your patient is in the AF or not in AF? Not in AF. So finally, your diagnosis. What is your diagnosis finally? Complete diagnosis. Final diagnosis. That's all. Anything else? No pulmonary hypertension features. Huh? Then if there is pulmonary hypertension, how can you say it should be prominent A wave, no? No pulmonary hypertension. Anything else? AF. Okay, that should be a complete diagnosis, no, not just mitral stenosis. It should be acquired valvular heart disease. Okay. I think because of the too much of delay, she lost interest in the entire presentation, I think. So much of delay. No, you keep it yourself. Anyway, you have to say inspection, palpation, auscultation findings. No? Anyway, I mean, there is a problem. No, once you catch the tail of the tiger, you cannot leave it. So till the end of the presentation, you cannot leave it. You cannot escape anyway. Okay, coming to JVP first. Okay, we'll finish off that. Abnormalities of the JVP. There are two important things to note. First of all, we need to know about the ways to measure JVP. So ideally, remember, it can be measured in any position, but at least for exams, you should say the patient should be seated at 45 degrees, which means we call it a semi-recumbent position, isn't it? So that is 45 degree, semi-recumbent. And the patient's neck should be relaxed. That is the idea. I mean, many students think that the neck should be turned towards the left or the right side. So what do you generally do? You turn the neck towards the left side or right side? Towards the right side. Towards the left side, because you are going to look at the right internal jugular vein, not on the left internal jugular vein. So why right IJV is better? Because of a lot of reasons. Because it's very straight and directly goes into the right atrium after connecting with the SVC. So the right IJV acts as a manometer for seeing the pressure changes in the right atrium. So that way we look at the right IJV. So to see the right IJV, many books will mention that you have to slightly turn the neck to the left, which is generally not needed. That's what is exactly shown in this image, which is generally not required, because when you turn the head towards the left side, it might result in a probable stretching of the facial compartments, which can actually obliterate the JVP. So the idea is you should not create any sort of tension to the neck. So if you create any sort of tension, your JVP will either be, because of venous pulsation, so it can be easily obliterated. So it will be either obliterated, or it can even disappear, or you can get a false value. That is why your neck should be in such a way, whether it is turned towards the left or whether it's neutral, doesn't matter. It should be just relaxed. Neck should never be tensed. That is the take home point. That's why this picture is there exactly. You need not turn the head towards the left, as contrary to the popular belief. Right, definitely you won't turn. That is different. But whatever may be the case, make sure that the neck is very much relaxed. That's all. And one more interesting thing is, what is shown here? What is shown here basically? So distance between the sternum and the right atrium. Okay, that is what I'm showing here. Here is the manubrium sterni. Here is the right atrium. And this association is fixed. It's only 5 centimeters. Irrespective of the body position, whatever may be the body position, even if the patient is lying down, or if the patient is in a semi-recumbent position, or if the patient, even if he's like sitting straight, it doesn't matter. This distance is standard. That is why we take that sternal angle as the external reference point. So if they ask you why sternal angle is considered as an external reference point, because the relationship between the right atrium and the sternal angle is not changed irrespective of the body position. That is the reason why we have chosen sternal angle as the external reference point. Okay. So once you know about the external reference point, now this is how you measure the JVP. This is called two-scale technique. So what you do is you keep one scale perpendicular to the sternal angle. It should be exactly perpendicular, because it's a common mistake that what you do is when the patient is in a semi-reclined position, you keep the thing straight. That's commonly you do, isn't it? That's a common mistake. Suppose the patient is like this, you tend to keep the scale like this. No, it should be like this. So it should be perpendicular to the sternal angle or perpendicular to the sternum itself. So you should not keep it straight. That's one important thing, very small thing, but very important thing. So here it's a perfect technique. As you can see here, the scale is extremely perpendicular to the sternum and the sternal angle. And once you have identified the JVP waveform, pulsation, at one point you have to see the meniscus. Remember, the top portion of the pulsation is what we call as meniscus. So once you have identified the JVP meniscus, maybe let me say somewhere around here, you have to keep another scale perpendicular to the original scale, and this distance will tell you the height of the JVP. Clear? This distance will tell you the height of the column, height of the blood column, that is the JVP. So the final measurement will be, for example, if you take this measurement as A, let us assume, if you have taken this measurement as A, the height of the blood column, it should be A plus 5 centimeter. You have to finally add 5 centimeter. That is very, very important. Do you understand or not? So all these things they would have taught you already. So it should be A plus 5 centimeter. Whatever you measure, that should be added with 5 centimeter to get the final jugular venous pressure in centimeters of water. Approximate measurements is what I'm trying to say here. Suppose if the pulsation is not visible at the level of the clavicle, so what could be the approximate value of JVP? It will be either normal or it can be low, which is less than 8 centimeter. This is what I was expecting from her. She was telling normal JVP, normal JVP, normal JVP. When I asked, she said 8 centimeter. But what do you mean by 8 centimeter and what is normal? So you need to define it, isn't it? So whenever your pulsations are not visible at the level of the clavicle, it means the JVP is either normal or low, or it can be, that means it is less than 8 centimeter. That's all. Exactly that's what I was expecting from her. To say that sir, pulsation is not visible at the level of the clavicle. So I'm saying it is a normal JVP, or it can be low JVP also. Then visible pulsations at the clavicle level means it will be approximately 10 centimeters of water. If the pulsations are visible up to the middle of the neck, then it will be 15 centimeters of water. Middle of the neck, it is 15 centimeters of water. If the pulsation is visualized up to the angle of the jaw, it is 20 centimeters of water. So how to answer an exam? It depends on your local policies again. So remember, generally, you will not be able to visualize the JVP. This is the really true statement. Okay, I'm not saying because I'm a student or I'm towards the examiner. Generally, you can't see the JVP if the patient is normal. So if at all the examiner is persistent about how can you not see JVP? If the patient, some people argue like if you don't see JVP, patient is dead. Like that, they will speak unnecessary things. If they speak something like that, if you feel like examiner is unnecessarily going into something, some into a dangerous zone, tell them it is seen just above the clavicle. That's all. See, the pulsations are seen just above the clavicle, and the height of the pulsation is approximately around 3 centimeter. The total JVP is around 8 centimeter. Done. So which is normal JVP also. You are not contradicting your own statement also. As simple as that. So that is how you have to answer. If you say like JVP is 8 centimeter, and if you see I'm seeing in the neck, that time itself I will understand that you are lying. How can a 8 centimeter JVP will be seen in the middle of the neck? Not possible. So typically, in Indian patients at least, JVP will be visualized just above the clavicle. That's where you see JVP. Beyond that, it's very difficult to see. Sometimes you may not be see, but still be careful in exam till it's seen just near the clavicle or just above the clavicle. Height is around 8 centimeters. That's all. Done and dusted. Everything will be over with that. So this is a very, very important table. That's why I told you separately. So whenever, whichever level you see JVP, this is the number that you're going to mention in the exam, approximate numbers. And there will be very common questions. How to differentiate between your internal jugular vein and carotid. So that is venous pulsation versus arterial pulsations. How to differentiate? So first of all, venous pulsations will be soft and diffuse. Diffuse. We call more as an undulant pulsations. In the sense, it will go like a wave. Venous pulsations. It will not be very sharp, or it will not be like, clearly felt or seen. It will be like a very soft, undulating waveform like appearance. It will be diffuse. It will not be localized to one particular area. It will be very diffuse throughout the neck, if at all, if you are able to see. That is typical of venous pulsation. Except in certain pathognomonic conditions, you will be seeing a very soft, undulating waveform only. Whereas arterial pulsations will be very sharp and external pulsations. It will be very well localized. In one particular area, you will be able to see the pulsations if it's arterial. Venous pulsations will be lateral and more superficial. Venous pulsation will be more lateral to the neck and more superficial, whereas arterial pulsations will be more medial and deeper. It won't be superficial. Generally, as I told you, venous pulsations will be having undulations, right? You will see double undulations. Why you have double undulations? Because you have both positive waveforms as well as negative waveforms. The positive waveforms are A and V, negative waveforms are X and Y descent. So you will see double undulations. Whereas arterial pulsations will be coming as a single pulse. Only single beat will be there. That's all. Nothing much. And you can see a definite upper level. That's why he's told like you have to comment on the meniscus, where you have seen the meniscus. So you have a definite upper level, but you don't have any definite upper level as far as arterial pulsations are concerned. Venous pulsations are better visible. They are practically impalpable. Arterial pulsations are palpable, sometimes can be visible. Okay, it's usually palpable, but sometimes can be visible also. But venous pulsations are usually visible only. Mostly it's impossible to palpate a venous pulsation, because even if you keep a slight amount of pressure, they will get obliterated because of the pressure in the venous system is very, very low. That's why. Next, venous pulsations will or venous pressures is going to change with your maneuvers, like respiration, body position, Valsalva. So many maneuvers can alter your venous pulsation. I'll tell you about the changes with respiration in a while. So it's going to change with respiration, body position, as well as Valsalva maneuvers. Whereas there will be no change with maneuvers as far as arterial pulsation is concerned. Even though BP might change with certain maneuvers, but pulsation wise, you will not be able to feel any much change. Venous pulsations, as I have been telling, it can be easily obliterated by compressing at the root of the neck. If you're just pressing on the root of the neck, you can easily obliterate it. But arterial pulsations, how much ever you press, you cannot obliterate unless and until you hang yourself in the ceiling. Yes or no? You know, forensic medicine you have studied, how much kilograms of weight if you give, how much pressure if you give, you can obliterate the carotid pulse so that you can go for unconsciousness, coma and death. Yes or no? So you need substantial amount of pressure. So because you are not going to do like this, to compress the artery. So which means easily if you press at the root of the neck, your venous pulsations will get obliterated. Even with tensing the neck, venous pulsations will go off. That's why you have to be very careful. You have to make sure that the neck is extremely relaxed. Okay, these are the differences between venous and arterial pulsations. And right internal jugular vein is the one that is preferred. As I told you already, left IJV is not preferred because left IJV is not straight. It comes here and then it has to pass towards the right side, then join the SVC. So it is something that's not going to be in direct connection with the right atrium all the time. And some people say that internal jugular veins have no valves compared to, because there is another question, why you prefer internal jugular veins than external jugular veins. Okay, why you prefer internal jugular veins? First point, many Indian textbooks will give is no valves. That is absolutely wrong statement according to literature. Almost every single literature and anatomical textbooks say that internal jugular veins does possess valves. In fact, any deep veins must possess valves. That is in nature. It is because the external jugular veins are very superficial, very, very superficial. They are easily manipulated by the changes in the facial planes and the pressures associated with the facial planes. Even a slight change in the pressure in the facial planes might completely obliterate the external jugular vein. So that is why we prefer internal jugular veins, which is slightly deeper to the facial plane and is not affected by any facial planes. Clear not? That's why we prefer internal jugular vein than external jugular vein. And why right? Because right has a straight connection with the right atrium. So right IJV acts as a kind of a manometer for the right atrium. So you know manometer, right? Depending on that, you can see the pressure and the water column will change. So like that, right IJV acts as a manometer for finding out the pressure changes in the right atrium. So that is the reason why I prefer right IJV. So two questions you need to answer. Why you prefer right IJV? And second, why you prefer IJV itself ahead of EJV? And third question is, what is the difference between arterial pulsation and venous pulsation? Fourth question will be, what is the technique of measuring JVP? And fifth question, why sternal angle is the external reference point? Why it is chosen as the external reference point? And sixth one, the technique of measuring JVP and the level of JVP. At what level, if you get the pulsation, and what level, if you get the meniscus, what could be the approximate pressure? So these are the important points that you need to know before jumping into the JVP itself. Okay. Now, what is the basic JVP hemodynamics? Jugular venous pressure hemodynamics. You know what are the waveforms it contains? You have A wave, then you have a probable small C wave, but generally C wave is not visible in humans. Okay, it's very difficult to visualize, but you can, if you are recording through some, like intravenous catheter, then you can probably record it, but it's very difficult under normal visualization. C wave. Then you have the X descent. Then we have the V wave. Then you have the Y descent. Okay, this is the normal JVP waveform. So this is the A wave, C wave, X descent, V wave, Y descent. And next time the A wave will start again in the next cardiac cycle. So if you want to correlate this with the cardiac cycle, how can you correlate with the cardiac cycle? Okay, let me draw this. Okay, this is one of my favorite diagrams. So many people will depict the cardiac cycle in many different ways. Some people will use the Vigor's diagram that you study in first year physiology. Some people will use a circular model for depicting the cardiac cycle. My way of understanding cardiac cycle is this kind of box diagrams. I mean, books don't give this, but I started using this very long back during my undergraduation itself. So this box diagram will be very easy to understand. That's why. So let us put separate diagrams for atrium and the ventricles. So in the atrium, in the ventricle first, let us start with. In the atrium, maybe I can say, okay, the first part is the atrial systole. First part is the atrial systole. Okay, remaining everything will be atrial diastole only. Remaining everything will be atrial diastole. So if you take a 0.8 second cardiac cycle, generally the average duration of cardiac cycle is 0.8 second for a heart rate of 75 beats per minute. So that's considered as average, 0.8 second cardiac cycle. In that, only 0.1 second will be what? Atrial systole, and remaining 0.7 second will be atrial diastole only. Now, next thing is ventricular systole and diastole. If you see, remember during atrial systole, the ventricle has to be in diastole. This is a very, very important concept. So it doesn't mean during atrial systole, ventricle is also in systole. If that happens, then no blood can enter into the ventricles at all. So during atrial systole, ventricle has to be in diastole to receive the blood that is coming from the atrium. So then only your ventricular systole starts. Typically, the ventricular systole, let us assume it extends up to this phase. It's approximately around 0.3 seconds. Ventricular systole. It's approximately around 0.3 seconds. So when you talk about ventricular systole, the initial part of the ventricular systole is called as what? Isovolumetric ventricular contraction. That is the initial part. So why it's called isovolumetric ventricular contraction? Because during that time, the ventricles will contract, but both the tricuspid and aortic valves will be closed. Obviously, during ventricular systole, tricuspid and mitral valves will close. There's no doubt. And after some time only, the aortic and pulmonary valves will open. Why? Because the pressure in the aorta and the pulmonary artery is relatively higher. So what is the pressure in the ventricle during the diastole? It's somewhere around 5 to 10 millimeters of mercury. But what is the pressure in the atrium? Even in systole, it is 5 to 10 only. Okay, atrial pressures are very low. The pressure in the diastole is 5 to 10 in ventricle. So as soon as the pressure in the ventricle goes above 5 or 10, your tricuspid and mitral valve will close. But your atrial aortic pressure is 120 and above systolic pressure, and aortic diastolic pressure is 80 and above. So until you reach that 80 millimeters of mercury, the aortic valve will be closed only. Once you go beyond that 80 only, the aortic valve will open. So till that time, the ventricle will contract, but neither the aortic valve or the mitral valve will be open. This is what we call as isovolumetric ventricular contraction. So after this small phase, your ventricular ejection will happen. Ventricular systole will take over and ejection will start happening. And you can further divide this ejection into two components. Okay. The first component, we can call it as a rapid ejection phase. And the second component, you can call it as a slow ejection phase. Okay, this is understandable only because as time goes, your force of ejection will come down. In the initial part only, the force will be rapid, as we all know. Then your ventricular diastole will start. This is ventricular diastole. So if you take ventricular diastole, it will be approximately 0.5 seconds. So I can write 0.4 seconds here and remaining 0.1 seconds here. So total duration of ventricular diastole is approximately 0.5 second in a 0.8 second cardiac cycle. So diastole can be further divided into three portions. The first portion is isovolumetric ventricular relaxation phase. Similarly, the ventricle will start the diastole, but your AV valves will still be open. Okay, and the mitral valves will still be open. Okay, but sorry, mitral valves will be closed, but this thing, ventricle will still start, relaxing, but there won't be any change in the volume as such. So that's why it is called as, similar to isovolumetric ventricular contraction, it is called as isovolumetric ventricular relaxation, initial phase. Then there will be one phase that is called as rapid passive filling phase. So what is rapid passive filling? As soon as the atrioventricular valves open, your blood that has been accumulating in the atrium during the diastole will open up and they will gush into the ventricles. Suddenly there will be a rapid gurgling of blood, and that is what we refer to as rapid passive filling phase. So please understand that during the time of ventricular systole, the atrium is in what? Diastole. So which means the blood is coming into the atrium during the time of diastole itself. It is coming from where? SVC, IVC, and from the pulmonary veins also. So actually the blood is coming from the great veins into the atrium, which means atrial filling is happening during the time of ventricular contraction itself. So all this accumulated blood till that is going to gush during the rapid passive filling phase. And after the rapid passive filling, still the blood will come from the atrium into the ventricles, but this blood will directly come from SVC, IVC, and pulmonary veins, which means whatever blood that's accumulated in the atrium has been going into the ventricles during the rapid passive filling phase itself. But from now on, in the slow passive filling phase, the blood that is coming into the atrium by SVC, IVC or pulmonary veins are directly trickling into the ventricles. So that trickling of blood is what we refer to as slow passive filling, or otherwise called as diastasis. Is that no? That's what we call diastasis. And finally, last phase of ventricular diastole is atrial kick. Atrial kick that happens with the atrial systole. So please understand that almost 80% plus ventricular filling is passive. In the sense, you need not have atrial kick to push this excess blood. I mean, push 80% of the blood. It's all passive filling only. Just opening of the atrioventricular valve is enough. That is enough to make the blood go into the ventricle. Only 20% of the ventricular filling comes from what? Atrial kick. And that has a very important clinical implication. For example, as I told you, 80% of the blood is filling the ventricles just by passive opening of the atrioventricular valves itself. So which means opening of atrioventricular valves is very important. And that contributes to 80% of the ventricular filling. So in general conditions, normally like you and me, the atrial kick is not that important. I'll tell you the importance later on, but still it's not that important as such for ventricular filling. But in certain patients, it becomes very important. For whom? Patients who are having mitral stenosis. So remember, in mitral stenosis patients, the AV valves will not open. That is, the mitral valve is not opening properly, which means the passive filling will be affected. If the passive filling is affected, then that extra effort has to be done by what? Atrium. The atrial kick will take care of the remaining pushing of the blood, because the passive filling is ineffective there, because the stenos do orifice. So atrial kick will be very powerful in mitral stenosis. That is why the left atrial pulsations will be very commonly visible in patients with mitral stenosis. Point number one. Second point, suppose if a MS patient goes for AFib, what happens? They will decompensate faster. The reason is because till now, mitral stenosis patients are maintaining their ventricular filling with the atrial kick. Once the patient goes for AFib, the atrial kick will be lost. So they'll go for acute decompensation pulmonary edema. That is why onset of AF is one of the important poor prognostic signs in patients with mitral stenosis. Are you understanding or not? So atrial kick becomes extremely important in patients with mitral stenosis, and you will lose the atrial kick in patients who are having atrial fibrillation. Because in AF, there is no contraction of the atrium at all. It's just fibrillating. So A wave in JVP, there are for certain no's in atrial fibrillation. What is the first no? You will not get P wave in the ECG. Second no, you will lose the A wave in the JVP. Third no. Fourth heart sound cannot happen because S4 is basically due to atrial kick only. What is the fourth no? No pre-systolic accentuation in mitral stenosis. Generally in MS, you will get a mid-diastolic murmur. As you all know, in the mid-diastole, you will get a murmur. And that murmur will disappear. And before the systole, you will get another murmur because atrium is kicking the remaining blood against the stenos orifice. So that is what we call as pre-systolic accentuation. And that pre-systolic accentuation is also due to what? Atrial kick only. So in AF, you will lose the pre-systolic accentuation as well. So what are the four no's in AFib? No P wave in ECG, no A wave in JVP. Next, no fourth heart sound. And number four, no pre-systolic accentuation in mitral stenosis. These are the four things that cannot happen if a patient is having atrial fibrillation. You should be very clear about that and very careful about that as well. So now this is the entire cardiac cycle in a nutshell. So first, you know what is the reason for A wave? A wave is due to what? Atrial contraction. Basically, A wave is due to atrial contraction. We all know that. And what is the reason for C wave? C wave is due to isovolumetric ventricular contraction. So why C wave happens? Basically, I told you during isovolumetric ventricular contraction, both the valves will be closed, but the ventricle will still continue to contract. But the aortic and pulmonary pressures are much higher than your atrial pressures. So what happens is this extra pressure that is building into the ventricle but it's lesser than that of the aortic pressure. So what will happen is it will try to push the mitral or tricuspid valve towards the atrium itself. So this buckling of the tricuspid valve during isovolumetric ventricular contraction into the right atrium is the reason for development of a small positive deflection that is called as C wave. Why it is called as C wave? Because originally it was thought to be a carotid artery artifact. Because isovolumetric ventricular contraction correlates with the carotid pulse, isn't it? I mean, timing wise, even though you might argue, but when manually if you see, it really correlates with the carotid pulse. Ventricular contraction, carotid pulse generally correlates with each other. But so what they felt is initially when they saw this kind of C wave, they felt it should be because of the carotid pulsation that is causing a sort of artifact in the JVP. So that's why they named it as C wave. That's called as carotid artifact. Later on, we understood it is not because of the carotid artery pulsation. It is because of the isovolumetric ventricular contraction causing buckling of the tricuspid valve into the right atrium, causing a slight increase in the pressure. So it's causing the positive deflection. Then what about the X descent? And some textbooks will confuse you. They will tell this is X dash descent. I'm not arguing with those things and all, but X descent means for me this only. And according to many authors, that is the X descent. But some books will confuse you. This is X dash. It's not the case. Okay. So this is X descent. That's all. So what is the reason for X descent? And which means this X descent is very, very important for the atrial filling. In fact, what is the reason for X descent? I'll tell you. So I told you initially your atrial systole is the reason for your A wave. Then your isovolumetric ventricular contraction is important for C wave. Now rapid ejection phase is the reason for development of X descent. So you may ask me how rapid ejection can result in the X descent. So what happens is whenever the ventricle contracts vigorously, what is contraction? It is shortening or lengthening of the ventricle. Contraction, shortening or lengthening? Shortening. Everyone knows. So ventricle tries to shorten in all the directions. So when it tries to shorten, it will pull the atrial floor downwards. Okay, because atrial floor is also part of the ventricle only. So atrial floor will try to, ventricle will try to pull the atrial floor downwards. So if the atrial floor is pulled downwards, that results in expansion of the atrial cavity. So the pressure will drop. So that creates a kind of a sucking effect. So that actually takes more blood into the atrium. Beautiful hemodynamics. Okay, that creates that negative pressure is important for what? Atrial filling itself from the SVC, IVC or the pulmonary veins. So that's the reason for X descent. So that is due to rapid ejection phase. Once the rapid ejection phase is over, the atrial floor cannot keep going down. At one point it will stop. So once it stops, the atrial filling will be rapid, and now the SVC and IVC will start filling the atrium. So slowly the pressure will start building because of the venous filling, and that is why we get the V wave. Venous filling. Venous filling means the blood from the SVC and IVC is filling and overflowing in the atrium. That's what it means. So that's why it's called V wave, venous filling. Then Y descent. What is the reason for Y descent? It is due to ventricular filling. So this happens once the atrioventricular valves open. So once the atrioventricular valves open, your blood will move into the ventricles. So that will result in the formation of Y descent. So Y descent will typically correlate with what? Rapid passive filling phase. Okay. Y descent will typically correlate with rapid passive filling phase. Are you understanding or not? That's all. So A wave is due to atrial contraction. C wave is due to isovolumetric ventricular contraction. X descent is due to rapid ejection phase of the ventricle pulling the atrial floor downward. And V wave is due to venous filling. Whereas Y descent is due to ventricular filling. You can correlate so many things with this. Okay, with a single diagram, you can correlate so many things. For example, where do you get the first heart sound? Isovolumetric ventricular contraction phase. Because during that time only your atrioventricular valves close. Maybe aortic and pulmonary valves are not open yet, but atrioventricular valves close, no? So that is the time you get S1. So during the isovolumetric ventricular relaxation, you get what? Second heart sound. Yes or no? During isovolumetric ventricular relaxation, you are going to get second heart sound because during the time only your aortic and pulmonary valves close, but nevertheless your AV valves will not be open yet. So it's a kind of relaxation with closed valves. That's why you call isovolumetric ventricular relaxation. Then where you will get this S3, third heart sound. Remember, in simple terms, third heart sound is due to ventricular increased end diastolic volume in the ventricles. In the sense, how do you say, ventricular volume overload state. Simply, whenever the ventricle is overfilled, whenever the ventricle is volume overloaded, you get third heart sound. As simple as that. So what happens is, whenever the ventricle is already volume overloaded, when the blood is coming from the atrium faster and is hitting the fluid column, that produces the third heart sound. Okay, that's a simple logic of how third heart sound is produced. Already overfilled ventricle, volume overload ventricle. Suddenly during rapid passive filling phase, the blood is gushing and coming and hitting on the fluid column already there in the ventricle. That produces the low pitched third heart sound. Because it's two fluids that is hitting with each other, so obviously it will be low pitched only. This is the accepted theory for third heart sound. So third heart sound should happen during what? Rapid passive filling phase. And as I told you, what is the mechanism of fourth heart sound? Atrial kick against a stiff ventricle. So you don't get S4, I don't get S4. Only if the ventricle is stiff, like atrium tries to give a kick to push the extra blood into the ventricle. So that atrial kick against a stiff ventricle is the one that produces fourth heart sound. So technically, where should you get the fourth heart sound? During the atrial kick. Technically. So logically speaking, S3 is a late diastolic sound or early diastolic sound. Remember, both S3 and S4 are diastolic sounds. There's no doubt about that. But S3 is a early diastolic sound. S4 is a late diastolic sound. That's all. So just one diagram is enough. You can answer everything easily. Another one I want to say. So when you get an opening snap, so remember, simple logic is closing of the valve should produce sound. Opening of the valve should never produce sound. When it produces sound, it is abnormal. If the atrioventricular valves open and if it produces sound, that's called snaps. If the aortic or pulmonary valve, if the seminal valves open and they produce sounds, that is called as ejection clicks. Yes or no? If the opening of the AV valves produce sounds, that is called snaps. If the opening of the seminal valves produce sounds, that's called ejection clicks. Technically speaking, where should you get the ejection click? Which area of the cardiac cycle? You should get the ejection click. During the rapid ejection phase, man, that is the time where you get the ejection click. Okay. Immediately after the isovolumetric contraction, during the rapid ejection phase only, you are going to get what? Ejection clicks. And where will you get opening snaps? During the rapid passive filling phase, but much before the S3. Okay, because for the blood to come, first of all, the valve should open. So logically speaking, opening snap comes much earlier than the third heart sound. Yes or no? So it's a very, very early diastolic sound, opening snap. Opening snap is also diastolic sound. There's another, diastolic sound that is called as pericardial knock. Pericardial knock. There's another sound, pericardial knock. So what is pericardial knock? It happens in patients with constrictive pericarditis. In constrictive pericarditis, the pericardium is very rigid. Normally, pericardium should be flexible. It should expand when the ventricle expands. It should contract when the ventricle contracts. It should become shorter. But in this situation, the pericardium is fixed. It doesn't shorten also, it doesn't lengthen also, it doesn't stretch also. So what happens during diastole? The ventricle has to expand because of the blood that is getting received into the ventricles. So if the pericardium is very rigid and during the passive filling, you know that the blood is going to come rapidly into the ventricles during the rapid passive filling phase. So during that time, the ventricular expansion should be assisted by the pericardial expansion. But here it doesn't happen. So initial part, the ventricle does try to expand, but once it hits the pericardium, it cannot expand any further. That hitting of the pericardium is what we called as pericardial knock. Is that no? Pericardium cannot stretch anymore. Okay, that stretching of the pericardium and hitting of the pericardium by the ventricle, that is a very crude thing to say, but maybe the stretch of the pericardium where it cannot stretch is going to produce that one. Pericardial knock, which is a maybe like it's also an early diastolic sound, but it happens before what? S3. Are you understanding or not? So these are the different heart sounds which comes at different places. Please understand, only 3 heart sounds, I mean apart from the normal heart sounds, only 3 sounds are low pitched. Remaining everything is high pitched. What are 3 low pitched sounds? S3, S4, tumor plop. Tumor plop is like opening snap only, but it happens in patients with atrial myxoma. That's all. Only 3 sounds in the entire cardiology are low pitch sounds. S3, S4 and tumor plop. Remaining every single sound is high pitched only. This is the only 3 low pitch sounds in entire cardiology. Okay, now you know what are the early diastolic sounds. Opening snap in order. Opening snap, pericardial knock, third heart sound. Late diastolic sound, S4. The most important late diastolic sound is S4. And ejection click happened during the rapid ejection phase. Are you understanding or not? And that is why the S2-OS gap is there, no? S2-OS gap is a predictor of severity. So understand, if the stenosis is very severe, MS is very severe, then what will be the pressure in the atrium? High or low? The blood cannot move down at all. So atrium will be ballooned up and the atrium will be at very high pressure. If the atrium is already at very high pressure, once the mitral valve opens, it is actually like waiting for the mitral valve to open to go into the left ventricle. So what will happen to the opening speed? It will be faster or slower? Faster. So more the left atrial pressure, faster is going to be the opening. So what will happen to the opening snap? It will come closer to S2 or it will become wider. It will come closer to S2 because opening will become so fast that the snap will almost be instantaneous with that of S2. So that's why narrowing of S2-OS gap is a marker of severity. Widening of S2-OS gap is a good marker. At least it's an early disease. That's what indicates. As the disease becomes severe, the S2-OS gap may become narrow and they can even become single also. At the same instant, you might get both opening snap and second heart sound. That is also one reason why in very severe AS, you might lose very severe MS, you might lose the opening snap. Because sometimes it can get merged with S2. Are you understanding or not? But people explain in a different way. They say that because of severe calcification of the valve, you will not be able to get the opening snap. But technically speaking, there might be opening snap, but because it happens almost instantaneously with S2, you will not be able to hear the opening snap separately. Are you understanding? Yes. So that these are all markers of severity, to be honest. So that is why this diagram is very important. And it tells you a lot of details where which heart sound comes and how to correlate with the JVP. For example, if you want to correlate the JVP, how will you correlate the heart sound to the JVP? Remember, first heart sound will be near what? C wave. Second heart sound will be just before the V wave, near the peak of the V wave. Nearing the peak of the V wave, you are getting the second heart sound. Okay, just before the V wave or nearing the peak of the V wave, you are going to get the second heart sound. Where will you get the third heart sound? Typically near the, if it is present, you will get near the Y descent, exactly on the Y descent, because both happens during the rapid passive filling phase. Where will you get the fourth heart sound? Near the A wave. That's where you get the fourth heart sound, because fourth heart sound is due to atrial contraction. So this also tells you the importance of palpating pulse simultaneously when you are observing the JVP. Remember, you cannot assess the waveform of the JVP unless until you palpate the pulse. Whenever you are looking at the JVP on the right side, you have to simultaneously palpate the carotid pulse on the left side. So if you don't do that, examiner will clearly understand that you have absolutely no idea about JVP. That's very, very important. If you want to see what waveform it is in the JVP, you need to definitely look at the carotid pulse simultaneously on the other side, not on the same side, of course. Same side is again rubbish, illogical. You have to see on the other side, because you have to correlate the waveforms based on the pulse only, because your pulse, carotid pulse will correlate with first heart sound, or at least you can even look at the heart rate, I mean heartbeat, you can auscultate simultaneously and you can look at the JVP. Even that is also fine. Do you understand or not? But carotid pulse is what I would suggest, because any positive undulation that correlates with the C wave, that correlates with the first heart sound, must be what? A wave. Because we cannot see the C wave. I told you. Any positive waveform that correlates with the carotid pulse must be what? A wave. Any positive pulsation that correlates with the second heart sound during auscultation must be what? V wave. Any negative undulation that comes between S1 and S2, what it should be? X descent. Any negative undulation that comes between S2 and S1 must be what? Y descent. Okay, that is the reason why you have to auscultate or at least palpate the carotid pulse and look at the JVP simultaneously. Without doing that, you will not be able to tell what waveform you are dealing with. Impossible. Because many times in the exam, I have seen students just seeing there and saying, sir, A wave is prominent. Because their diagnosis is MS with pulmonary hypertension, they will say A wave is prominent. So at least, even if you're not able to see the A wave properly, at least do the technique properly. That's what I expect. So even I may not be able to see A wave sometimes. But at least what we expect is the technique, whether you touch the patients or not. See, even though clinical examination is something that is getting outdated slowly, but still why in some reasons, some reasons why it is still important is because it gives you an opportunity to touch the patient. It gives you an opportunity to handle the patient with care. Okay. Anyway, you're dealing with someone else. So how to be empathetic and sympathetic. So that is the reason why still it has a lot of relevance. So that is why we wanted the technique to be correct most of the time. So look at the right technique. That's more important. I think this explains you the important phenomenon of JVP, and entire physiology of JVP can be seen with this. So now we are going to the abnormalities. And what is a normal JVP? 5 to 8 centimeter. Okay, this is a normal JVP. 5 to 8 centimeters of water. And next important physiology that you need to know before going into the abnormalities of JVP is the changes with respiration and with the changes in posture, especially. But respiratory changes are very, very important. So let me tell you some important respiratory changes. Okay, I'll summarize later on, but let me tell you. During inspiration, what happens? What happens during inspiration? Your intrathoracic pressure, not negative, decreases. Okay, so pleural pressure only will be negative always. Intrathoracic pressure only transiently becomes negative. At the end, inspiration becomes 0. Okay, all right, fine. So anyway, the pressure is going to drop in inspiration. So if the intrathoracic pressure drops, what will happen to the blood that is coming into the thorax? It will increase. So it's going to suck more blood. What amount? What blood? It's arterial blood or venous blood? Venous blood. In either ways, for example, we can say in other way also, because during inspiration, diaphragm is going down. If diaphragm goes down, what happens to the abdominal pressure? Abdominal pressure will increase actually. Okay, because diaphragm is going down. The abdominal cavity is shortening. So the pressure in the abdomen will increase. That will actually compress your IVC and SVC. At the same time, your thoracic cavity is expanding, creating a negative pressure that sucks in more blood into the thorax through IVC and SVC. So your right atrium and right side of the heart is actually getting more blood. This is what is happening in inspiration. So how will you remember that? So you can remember with a mnemonic called right. Okay, right-sided flows will increase during inspiration. Yes or no? Similarly, exact opposite will happen on the left side. So as the lungs increase in size, as the lungs stretch in size, what happens to the pulmonary vasculature? They also stretch because the lung elasticity that stretches the lungs, the same thing is also stretching the pulmonary capillaries and the pulmonary vasculature. So once you stretch the pulmonary vasculature, what will happen? The blood will accumulate in the pulmonary vasculature. So the blood is not moving from the right side to the left side properly. So the amount of blood that is going to the left side is actually decreasing. But opposite happens in expiration. So what happens during expiration? your intrathoracic pressure rises, your diaphragm goes up, so intra-abdominal pressure reduces. If intrathoracic pressure increases, your great veins will be cut off. In the sense, I'm not telling it will be completely cut off, but amount of blood that is entering into the thorax will reduce dramatically. So if it reduces dramatically, what happens to the right-sided filling? Reduces. But by the same principle, your pulmonary capillaries, because the lungs are shortening, the pulmonary vessels are squeezed. Whatever blood that is accumulated will be squeezed and pushed into the left side. So in this situation, what will happen to the left side? Left-sided volume is increasing. So your BP is going to increase during expiration. That is why, again, if you want a mnemonic, you can remember something like this. Left-sided volumes and left-sided flow is increased during expiration. So only right has I and left has E. So you can easily remember that. Okay, right-sided flows increase with inspiration, left-sided flows are going to increase with expiration. So one more interesting thing I will tell you. What happens during inspiration and what happens during expiration? So if you talk about the flows per se, the right-sided flows are increased with inspiration, whereas the left-sided flows are increased with expiration. Similarly, when you talk about JVP as such, pressure as such, it's going to decrease with inspiration and increase with expiration, as we all know. Why? Because during expiration, because of increased intrathoracic pressure, the movement of blood from IJV into the thorax is reduced. So the blood will get accumulated and that will result in increase in the JVP, jugular venous pressure. But to be honest, the pulsations, JVP pulsations will be better visualized during inspiration compared to expiration. Why? 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 Because during inspiration only, the IJV will be in direct continuity with the right atrium. During expiration, there is a chance that JVP might get kinked because of the increased intrathoracic pressure. So the pressure may not be transmitted to the IJV properly during expiration. Yes or no? Only when the pipe is in continuity, proper continuity, you will be able to see the pulsations properly. If the pipe is kinked or if it's not having sufficient continuity, as what happens during expiration, you might increase the pressure because of accumulation, but the pulsation transmission will be poor as well. That's why you will not be able to see proper pulsations during expiration. What happens to the blood pressure? Blood pressure also decreases with what? Inspiration. It increases with expiration for the reason I told you, the pulmonary vasculature reason. What happens to intrathoracic pressure? That also decreases with inspiration and increases with expiration. But what happens to intra-abdominal pressure? It increases with inspiration and decreases with expiration. Yes or no? It's a very simple hemodynamics, but very important to know. Which means both JVP and BP decrease with inspiration. And both JVP and BP increase with expiration. Do you agree or not? Yes. Both the pressures decrease with inspiration and both the pressures increase with expiration. And similarly, I told you the right-sided flows are going to increase with inspiration. So if there is any pathological events, that will also get worsened with what? Increased flow, and because of that you will be able to see more clinical signs during inspiration if it's a right-sided pathology. And this is what we refer to as de Carvalho's sign or de Carvalho's law. He first described this for TR, okay, tricuspid regurgitation. First de Carvalho described this problem with TR only. So TR definitely accentuates with inspiration. The murmur will be heard much better with inspiration. But only one exception for this rule is primary pulmonic stenosis, PPS. We saw in Williams syndrome, no? Not Williams, Noonan syndrome. Williams, we saw supravalvular AS. Noonan's primary pulmonary stenosis. Yes or no? The only exception that disobeys the de Carlos law is ejection sound of primary pulmonary stenosis. That tends to get increased with expiration and decreased with inspiration. That's the only one that disobeys the de Carlos law. Even though this is important for clinical exam, this was asked in JIPMER once. 2017 JIPMER, they asked this. I don't know why they asked, but they asked it. That's the only event that disobeys the de Carlos law. Similarly, as you all know, on the left side, the events are going to worsen with what? Expiration or inspiration? Expiration. That is why most of the left-sided events, pathological events, you ask the patient to hold the breath in expiration. So how will you examine mitral stenosis? Finally, you say, no, the murmur is best heard when the patient is in expiration. For aortic stenosis, what do you say? The murmur is best heard when the patient's breath is held in expiration. So why you say that? Because most of the pathology events on the left side will get accentuated when the patient is on expiration. There is no law for that. De Carlos law is applicable only for the right-sided events, not for the left-sided events. Do you understand or not? So this is the JVP change with regards to position. Sorry, with regards to respiration. And similarly, when the patient lies down, JVP might increase. Why? Because of the increased venous rhythm. And similarly, when you do another maneuver called as jugular reflex, okay, during that maneuver also, JVP might increase. So how do you do jugular reflex? You are going to press an area So this is the umbilicus, this is the midline of the body. You have to press an area that is exactly midline between the right flank and the actual midline. A little bit lower in the right hypochondrium. So technically right hypochondrium only, but they have defined that area also. So just some 3 to 4 centimeters to the right of the midline. Okay, that is where you are going to press. So how much pressure you are going to apply? See, remember, everything in clinical medicine should be quantified. How much pressure you should apply? Approximately 40 millimeters of mercury. This is the amount of pressure that you should apply. How will you know that you are applying 40 millimeters of mercury? Actually, it's something that can be done. Even Valsalva also, the pressure that you have to give is 40 millimeters of mercury. Everything should be quantified. In our hospital, we have a separate cardiac autonomic monitor. Okay, in cardiac autonomic monitor, when any patient who comes with syncope or giddiness or pre-syncope, we will test for cardiac autonomic activity. So one of the important tests of cardiac autonomic monitoring is your Valsalva maneuver. So in Valsalva, you cannot just ask the patient to blow into something. You should quantify, and the pressure at which the patient blows should be 40 millimeters of mercury. So how will you do Valsalva? You can connect it to a sphygmomanometer. Okay, and the sphygmomanometer pipe can be connected to a 10 ml syringe. Okay, and in the 10 ml syringe, you put a small hole in the side. So patient should not develop excessive undue pressures. So if the sphygmomanometer, if you don't put a hole in the syringe, then even a little bit more pressure also will rapidly cause fluctuations. So if you put a hole means some pressure will escape out and the patient will be okay with maintaining with a constant pressure. So if you blow it through that, now you can clearly see that the sphygmomanometer will be, you instruct the patient to make sure that after blowing, you should maintain the mercury column at 40. With 1 or 2 trials, the patient will understand what we are trying to say. So you should say that you should blow in such a way that the mercury column should be maintained at 40. So it's very easy. You can do it. Valsalva should be also at 40 only. Similarly, here, how will you do? Same mercury sphygmomanometer, you take the cuff, roll it, and place it on the patient's abdomen and press it. Do you understand or not? When you place the this thing sphygmomanometer cuff on the patient's abdomen and you press it, obviously you are going to give how much? 40 millimeters of mercury exact pressure. So that should be the amount of pressure that you should give, not more than that. Okay, that is the actual jugular reflex. So when you give this much of pressure, what are you going to look out for? You are looking at increase in the jugular venous column, increase in the jugular venous pressure, plus the duration of increase as well. Both are very important. Many people forget this duration. Both increase in the JVP in absolute quantity as well as the duration of increase also very important. If the JVP increases by more than 3 centimeters from the baseline, plus if it is elevated, sustained for more than 15 seconds, both should be there. Then only this test is considered to be positive. It's a positive epidojugular reflex. It is not just elevation beyond 3 centimeters. It should be sustained for more than 15 seconds. If this is the case, this indicates a right heart failure. This is one of the old clinical signs because edema may be due to many causes, cirrhosis, then so many causes can be there. But whether it is due to right-sided heart failure or not, this test will tell you. Elevation of JVP that is sustained for more than 15 seconds by at least more than 3 centimeter elevation is considered to be positive epidojugular reflex. If it is elevated more than 3 centimeters, but it is not sustained for 15 seconds, the test is negative only. If the JVP is not getting elevated by more than 3 centimeters, if it's elevated only by 2 centimeters, but elevated more than 15 seconds, still it will be negative only. So both criteria should be satisfied. Then only it will be considered to be positive. There is another condition where you can get an absent epidojugular reflex. Absent epidojugular reflex, which means you may not even get the epidojugular reflex, which means there will not be even a slight bit of elevation in the JVP, how much ever you press. So this will be typically seen in SVC obstruction. Because no matter what you do, the pressure changes cannot be transmitted. Yes or no? Do you understand or not? Because of obstructed SVC, the pressure change in the right atrium cannot be transmitted. But this is the one condition where JVP will be high, but epidojugular reflex will be absent. You will not be able to see the epidojugular reflex at all. But JVP will be elevated. The reason is very simple. Look at IVC. So if you say this is the right atrium, and this is the right ventricle, let us assume, and you know this is the SVC. I'm just drawing an arbitrary diagram. So this is the SVC, and this is the IVC, right? What epidojugular reflex does, it pushes more blood into the tricuspid valve. It pushes more blood into the right atrium. And that more blood is going to push the pressure in the SVC. So because right IJV is in continuity with the right atrium, so this pressure transmission will be seen in the right IJV. But suppose if you have an obstructed SVC, what will happen? If you have an SVC obstruction because of some tumor or something, what will happen in this situation? Definitely the blood cannot come down. So definitely the JVP will be high because this downward movement will not happen. Plus at the same time, whatever pressure change you give in the IVC, it will increase the right atrial pressure, but this pressure change will not be transmitted into the JVP. So that is why you have an elevated JVP in SVC obstruction, but you don't get epidojugular reflex at all. It will be absent altogether. So this is a very, very important condition. Absent epidojugular reflex. If they ask you where you will get in patients with SVC obstruction. Okay, do you understand this? What's happening? Now let us move on to the abnormalities. Abnormalities. First, let us see the abnormalities of the ascents. Very few things only they will expect you in exam. Okay, that much only I'm going to say. First, A wave, very, very important. So when it comes to A wave, you have something called prominent A wave. Prominent A wave. So where will you get prominent A wave? So what is the reason for A wave? Atrial contraction. Where the atrial contraction will be powerful? In patients with tricuspid stenosis. Number one, A wave will be prominent. Second, in patients with stiff ventricle, I told you, where the ventricle will be stiff if the patient is having pulmonary hypertension. We are talking only about left side, right side events, not left side events. Okay, pulmonary hypertension. Only these two conditions are very, very important. Suppose if you want to say a congenital heart disease, remember congenital heart disease generally will not give rise to any JVP changes. Whatever common congenital heart disease that you see will not give rise to any JVP changes. JVP changes will be inconspicuous only. But one area or one or two areas where you might see JVP changes is tricuspid atresia. Tricuspid atresia. It is very similar to tricuspid stenosis only, isn't it? Second area where you can see this thing is probably maybe another congenital heart disease. No. Pulmonary stenosis with intact septum. Or pulmonary atresia with intact septum. Pulmonary stenosis with intact septum or pulmonary atresia with intact septum. Okay, this is another condition where you can see very large J wave. Remember, TOF will not cause the large J wave. Why? Even though in TOF you have infundibular pulmonary stenosis, right? In TOF, one of the features of Fallett's tetralogy is infundibular PS, pulmonary stenosis. Yes, because of the VSD. Because the pressure is shunted to the other side. That's why you will not get large JVP. But majority of the congenital heart disease, JVP will be inconspicuous only. You need not comment on the JVP. This is a universal rule, generally. Okay. Epstein's anomaly will produce prominent A wave or no prominent A wave. Because in Epstein's anomaly, even right ventricle has become atrium. So you'll get an A wave or you will not get A wave. Epstein's anomaly. You will not get an A wave, prominent A wave. Instead, in Epstein's anomaly, you will get a prominent C wave. The only condition where you can see C wave in clinical practice is Epstein's anomaly. No other condition you can see C wave. Only one condition is Epstein's anomaly. Prominent C wave. If you answer this, definitely you will get gold medal. For sure. The only condition where you can see prominent C wave is Epstein's. Nowhere else. And why A wave is not prominent in Epstein's? Because of the ASD. Again, Epstein's anomaly will be usually associated with atrial septal defect, and there will be significant shunting of the blood and pressure to the other side. So if the pressure is shunted to some other area, you will not get any particular waveform. So these are the important entities that can produce prominent A wave. Another medal exam question is aortic stenosis can cause prominent A wave. That's extremely rare, but aortic stenosis can produce prominent A wave. That is called as Burnham effect. Burnham effect. Okay, aortic stenosis. That's called Burnham effect. So why? Because in aortic stenosis there will be significant left ventricular hypertrophy. No pulmonary hypertension. No significant. See, aortic stenosis, if you see pulmonary hypertension means, I mean, it's very rare case or the patient is going to die in few days. That's what indicates it. It's not, I don't think it's possible. You should never comment on pulmonary hypertension as far as AS is concerned. AR, AS never produce pulmonary hypertension. MS, MRS, ASAR, no, not at all. But why it produces prominent A wave is because aortic stenosis is a condition produce LVH, and left ventricle includes the septum also, right? And in severe AS, the LV along with the septum might become very, very thick. So that might compromise on the right ventricular cavity. So the right ventricular cavity will become slightly non-compliant. So in severe AS, because of the thickening of the LV and the septum and compromisation of the right ventricular cavity and resulting in a stiff non-compliant right ventricle is what we call as Burnham effect. And that can result in large A wave. That's extremely rare. Okay, but you can get it technically. But at least in your exams, the first two causes are going to be very, very important. If you're not able to tell the first two causes also, then you will be in trouble, surely. So you have definitions also. So some people call it as giant A wave. Some people call prominent A wave. But again, in cardiology, everything has to be quantified. So how will you tell it's a giant A wave? Because something can be canon for you, something can be giant for me. So how will you quantify it? So prominent A wave means 3 to 6 millimeters of mercury. The A wave pressure should be 3 to 6 millimeters of mercury. Giant A wave means it will be 7 to 15 millimeters of mercury. That's the definition of giant A wave. And prominent A wave as well as giant A wave, you have similar causes. Okay, both are same cause only the pressure is different. The cutoff is different, but apart from that, everything is the same. And third thing what you can get is something called as Canon A waves. That's called as Canon shots. Canon A waves, technically speaking, you will be knowing the definition by now. The pressure should be more than 15 millimeters of mercury to say it's a Canon A wave. Where you will get such a high pressured A wave? In patients where atrium and ventricle are contracting simultaneously. I mean, many people will say like contraction of atrium against a closed tricuspid valve. But my concept is completely different and same only, but understanding is different. When atrium is contracting against a ventricle, that is also contracting at that time. When both are simultaneously contracting, obviously ventricular pressures are higher, so your tricuspid valve will be closed. So you are going to result in contraction of atrium against closed tricuspid valve. That will result in backflow and regurgitation of pressure, causing a Canon shot. So what are the conditions where atrium and ventricle will contract simultaneously? So there are two areas where it can contract simultaneously. One is in patient with SVT, supraventricular tachycardia. So what happens in SVT? Typically in AVNRT, typically in a atrioventricular nodal reentrant tachycardia. For people who don't know what is AVNRT, here, I mean, simply I would say AVNRT is AV nodal reentrant tachycardia. For people who don't know what is AVNRT, I would explain this simply. So you have a AV node. In this patient, there will be an arrhythmic circuit that will be generated in the AV node. So there will be an abnormal circuit that is rotating within the AV node. Every time the circuit rotates around the AV node, there will be one impulse that will be thrown into the atrium and one impulse that will be thrown into the ventricle. So what's happening here is you will get a QRS complex because of your ventricular depolarization. Plus at the same time, because of atrial depolarization also, you will be able to get a P wave in the ECG. And this P wave will be almost near simultaneous with the QRS complex. So that in the ECG, actually, it's very difficult to see the P wave because it will be buried within the QRS complex. But at least you can understand that both atrium and ventricle are almost depolarizing simultaneously. But under normal circumstances, it should come from the SA node, then to the AV node. AV node will hold the impulse for some time. After that only it will release the impulse in the ventricles, which is very critical for atrial emptying into the ventricle. But if both couple together by this abnormal circuit in AVNRT, means you are going to result in this kind of Canon shots. Okay, this will produce regular Canon waves or irregular Canon waves. Regular Canon waves. Why? Because every time the impulse rotates, you get atrium and ventricular depolarization. So with every pulse, you will see a simultaneous A wave also. That's a regular Canon wave. Second area where you can get is AV dissociation. AV dissociation. So what do you mean by AV dissociation? See, normally only one pacemaker should control the heart. It could be normal pacemaker or abnormal pacemaker. So if you see this example, this is an abnormal pacemaker, but still it's only one pacemaker controlling both atrium and ventricle. Similarly, like SA node. SA node is the one that controls both atrium and the ventricles. Likewise, in this example also, one pacemaker controls both atrium and ventricles. So there is no AV dissociation. Both are coupled together. But when you see a condition like ventricular tachycardia, so what happens in ventricular tachycardia? There will be SA node that will be firing its own impulses. AV node is here, all right. But there will be another circuit that will be firing in the ventricles that is causing VTAC. So there are two different pacemakers actually controlling two different areas of the heart. So here atrium is controlled by SA node, whereas ventricles are controlled by ventricular ectopic pacemaker. So this is AV dissociation. So what happens here? You will get typically a broad complex QRS like this. Okay. Here you will get the QRS regularly because this is coming from this pacemaker. And you will be getting what? P wave also, but the P waves will not have any relationship to the QRS complex because it will come one P wave here, one P wave here, one P wave here. Suddenly, one P wave might fall over the QRS complex, and that time you might get Canon A wave. Do you understand? So that is why one of the important examples of AV dissociation is VTAC, ventricular tachycardia, and that becomes a very important cause of Canon A waves. In AV dissociation, you will see irregular or regular Canon A waves. I told you already. Maybe sometime 1 or 2 P waves might correlate with the QRS complex, and that time you will get Canon A waves. So you will be getting only irregular Canon A waves. You will not get regular Canon A waves. Another condition where you can get AV dissociation is complete heart block, 3rd degree heart block. So what happens in 3rd degree heart block? Very similar principle. Very similar principle in 3rd degree heart block, but what happens is, here you have an SA node that is firing as usual into the atrium, but here the AV node is completely blocked. So when AV node is blocked completely, it's not working at all, not even transmitting one impulse. In this situation, there is a need that some lower parts of the AV node, lower parts of the AV node itself, or some bundle of his or Purkinje fibers or something is going to take over as the pacemaker for the ventricles. So now they will control the ventricles, because these are called as escape rhythms. It is to save your life. Okay. So even in complete heart block, still patients are alive, isn't it? So this is the reason. These are called escape pacemakers. So even in this condition also, same thing is happening. What? There is 2 different pacemaker which is controlling atrium separately and ventricle separately. So this is an example of what? AV dissociation. And what this pacemaker does, this pacemaker has no idea, and both are working independently of each other by the same principle of AV dissociation. Some of the P waves sometimes, I mean, without their knowledge itself, can superimpose on the QRS complex, resulting in AV dissociation, and thereby you can result in complete heart block, Canon A waves. So whenever a patient is coming with hypotension, just by looking at the patient, you can say, if you have a Canon A wave, look at a regular or irregular. Regular, SVT. Irregular, think about a VT or complete heart block. See the pulse. If the pulse is high, if there is a tachycardia, think about VTAC. If the pulse is low, bradycardia, think about complete heart block. That's all. So many times we have found this in casualty itself. To be honest, even before taking the ECG, I used to tell this to my juniors. Take an ECG, it will be a VTAC. Not because of anything else, just because of this understanding of JVP. This Canon A waves will be so, prominent that you can see so easily actually. It's not very difficult to look at all. I'll show an example of Canon A wave. You can see that chain is getting lifted. So normally, you know that JVP is something that gets obliterated so easily. But see, the pressure buildup is so high that in this patient, the chain itself is getting lifted. This is a regular Canon A wave or irregular Canon A wave? It's a regular Canon A wave. So if you see it's a regular Canon A wave, what should be your diagnosis? SVT. Typically an AV NRT. And this kind of regular Canon A waves, remember, Canon A waves means JVP means it won't get only transmitted on the right side. It's going to go into the left side also, because continuity is there on both the sides. So both sides you might get pulsations in the JVP. With each heartbeat, both sides you will get pulsations, Canon A waves, and that is referred to as something called frog sign. So what is frog sign? Like a frog during winter and during rainy season, they put their vocal cords like this. We have seen frogs, right? So which does the vocal cord something like this to attract the females to make them pregnant. Do you remember? Yes or no? Something like that happens, no? In these patients, JVP is expanding in the neck. That's called frog sign. Do you remember yesterday I said, whenever the patient tells pounding sensation, you should ask whether pounding sensation is in the chest or pounding sensation is in the neck. Whenever pounding sensation is in the neck, it indicates what? Canon A waves. Did I tell you yesterday or not? That's why. Okay, this is an example of Canon A waves. Then you can have abnormalities of the V wave ascents. And what about the normal ascents and descents? I mean, if you see this diagram closely, I've drawn it correctly, to be honest. So remember, A wave is always tall, normal A wave is always taller than the V wave. And X descent is deeper than the Y descent. This is the rule. Normally itself, your A wave will be taller than the V wave, and your X descent will be deeper than the Y descent. This is very normal. Straightforward. What are the conditions that produce large V wave? What is the reason for V wave? What is the reason for V wave? venous filling. Venous filling happens during ventricular systole or ventricular diastole. Venous filling of the atrium happens during ventricular systole or diastole. Ventricular systole. Okay. I told you when the ventricle contracts only, it puts the atrial flow downward so that you get the venous filling. And that is the reason for X descent. But after that, during the V wave, that happens during the slow ejection phase. Still, it is during ventricular contraction only. So, where will you get a large V wave? Large V wave. Where will you get a large V wave? The typical characteristic example is tricuspid regurgitation. Because in TR, during ventricular systole, instead of blood moving into the pulmonary artery, it's moving into the atrium. Yes or no? So technically speaking, in TR, the right atrium is receiving blood from both SVC and IVC as well as from ventricles. So there is abnormally high venous filling. Do you understand or not? That is the reason why you get a large V wave. Typical characteristic example is your what is that? TR. But Epstein's anomaly is a condition where you get what? TR. Okay, you will get a TR in Epstein's anomaly. But despite having significant TR, you won't get a large V wave in Epstein's anomaly. What is the reason? Okay, one is because of ASD. Second reason is because in Epstein's anomaly, there will be atrialization of right ventricle. So the functioning right ventricle will be very small and it will not be powerful. Do you understand? Only small right ventricle will be functional. And that contraction will not be very conspicuously going to cause a large V wave. So that is the reason why you don't get a large V wave in Epstein's anomaly, despite the fact that you have a significant TR. Okay, apart from that, patients who are having where else you can have increased venous return? TAPVC. That's called total anomalous pulmonary venous connection, or it could be partial anomalous pulmonary venous connection also. Total anomalous pulmonary venous connection or partial anomalous pulmonary venous connection. Do you understand? What is total anomalous pulmonary venous connection or partial anomalous pulmonary venous connection? So pulmonary veins are wrongly connected to the right atrium. So the right atrium in this condition is not only receiving blood from the SVC and IVC, it's also receiving blood from the pulmonary veins. That's why venous return is very high. Next, ASD. ASD will not have a large A wave, but they will have a large V wave because shunting from the left atrium to the right atrium. Venous return is increasing. That's why. Apart from that, you can get in constrictive pericarditis. Why in constrictive pericarditis? Because of the poor right atrial compliance. During the like atrial kick, your ventricle will not receive adequate blood. So there will be large amount of blood that is already left in the right atrium. So the venous return that is coming from SVC and IVC is adding on to the blood that is not already moving down. So large venous return, technically speaking, so you'll get a large V wave. Then probably for the same reason in congestive cardiac failure, right ventricular failure, you might get a large V wave. So these are the important conditions. But at least in exam, you should be able to answer TR, tricuspid regurgitation, which can cause large V wave. The least minimum is something that you need to know. And what will be the typical feature of TR? In TR, you will have a wave, and there will be obliteration of the X descent. Why there is obliteration of X descent? Because during X descent, there is ventricular contraction resulting in rapid ejection phase. But in TR, the atrial floor is pulled downward, but instead of creating negative pressure, the regurgitant blood is creating a positive pressure. So you will not even get an X descent. So that's why in TR you get an obliterated X descent as well. So technically, you will see something like this. Okay, normally what I told you, the X descent should be what? Deeper than the Y descent. But here it reverses. X descent will get blunted. And you will get what? Large V wave. The opposite to what I said. Normally A should be more than V and X should be more than Y. But in TR, X will become less deeper than Y, and your V wave will become taller than A wave. So as the TR worsens, okay, So it becomes severe TR. You might have complete loss of X descent, and you might result in a pattern like this. This is called as CV fusion. You will get a large V wave. Along with that, you will lose the X descent completely. That is what we refer to as CV fusion, which means it's the regurgitant jet that is causing a large CV wave. So now it's no longer called as X descent or V wave. It should be called as CV wave. That regurgitant jet is creating a large CV wave. And this can actually displace the earlobes. It can be so high that it can actually displace the earlobes. You can see earlobe pulsations with every beat. Because of TR jet, you can see earlobe pulsations, and that is called as Lance's sign. That earlobe pulsations in TR is what we call as Lance's sign. In this patient, you need to watch the earlobe carefully. Can you see the earlobe pulsations? Are you able to see? The earlobe is actually lifted little. This is a large TR jet that is going into the IJV. So this is what we refer to as something called as Lance's sign. Very, very important. Do you understand or not? So these are the problems of the V wave, basically. And as far as X descent is concerned, what are the conditions where you have a reduced X descent? Reduced X descent. X descent is due to ventricular contraction, RV dysfunction. Simple example. Yes or no? X descent is due to contraction, no? Ventricular contraction. If ventricular contraction is not powerful, you will not see a big X descent. It's going to be obliterated. Second reason is what? TR. Just a while ago I said. Third condition is AFib, atrial fibrillation. In AFib, because atrium is not contributing to the ventricular diastole, isn't it? So atrium is not contracting. So the amount of blood that you are going to get in the right ventricle is less. So because the amount of blood entering the right ventricle is less, the force of contraction is going to be less. So if the force of contraction is less, your X descent will not be deeper. It will be diminished. There will be reduced X descent. Okay, what are the conditions where you will get reduced Y descent? Or maybe you can say prominent Y descent, more than reduced Y descent. Prominent Y descent. The characteristic example for this is constrictive pericarditis. Constrictive pericarditis. Prominent Y descent. So what is the reason for Y descent? Ventricular filling. Okay, that is the reason for Y descent. But here, why it is prominent? Because there are multiple reasons for that. One main reason is, see, ventricle, it's very difficult to say, but anyway, if ventricle fills during diastole, how much if it fills is important to say how much end systolic volume you have, how much you are going to have at the end of the systole. Suppose if the ventricle is going to fill a lot, the amount of volume that will be left after the systole also will be a little high. Easy to understand. Suppose if the ventricle is filling only little, means what will be the amount that will be left at the end of the systole? Little. Only little blood is coming, it will contract almost everything. So the ventricle will almost be empty at the end of the systole in constrictive pericarditis. Why? Because during diastole, the filling is restricted by that pericardium, which is thickened and rigid. So because the filling is restricted, but the contraction of the ventricle is okay, so it's going to eject almost entirely, and the amount of end systolic volume is very, very less. So at the end of systole, you will not have any volume. So after systole, when you start the diastole, the ventricle will vigorously receive blood. If the ventricle is already having some blood, it's not going to receive that much. But if the ventricle is empty at the end of the systole, during the diastole, it can suck in blood vigorously because it's empty. It can receive a lot of blood. So that's why you get a deeper Y descent. Actually, everything can be explained, but it will take time, that's all. So that's why you get a deeper Y descent here. Very prominent Y descent. Classic example is your constitutive pericarditis and patients with hyperolemia and patients who are having RV dysfunction. More than RV dysfunction, you can say pulmonary hypertension, RV dysfunction, pulmonary hypertension, cardiomyopathies. In all these conditions, you will have a prominent Y descent. But most important condition is constitutive pericarditis. That at least you need to say, where you are going to have a prominent X descent. So where you will have a diminished Y descent. Diminished Y descent. What are the conditions where you have diminished Y descent? One is tricuspid stenosis, because Y descent is because of ventricular filling. In tricuspid stenosis, you will not get adequate ventricular filling. So Y descent will be restricted. Number two is tamponade, cardiac tamponade. Second is cardiac tamponade. In that, the most difficult to understand is the tamponade and the constitutive pericarditis physiology. So first, let me tell you the tamponade physiology. So what happens in tamponade? You have a heart and there is fluid around the heart. That's what is happening in tamponade. Fluid around the entire heart, which means including all the atrium as well as the ventricles, everywhere, not only in one place. So in tamponade, generally what happens is the total cardiac volume becomes fixed. Total cardiac volume becomes entirely fixed. The entire cardiac volume can neither increase nor decrease. It will become in that way. So which means for the blood to enter into the heart, blood should move out from the heart at the same time. Because the volume is fixed, because the fluid around the heart, the amount of blood that is entering the heart means at the same time, same amount of blood should go out of the heart. Then only that, what is that? Blood that is coming in can come in the first place. So what happens is, during Y descent, the ventricle is in diastole. Ventricle is not ejecting any blood. Understand? During Y descent, ventricle is in systole or diastole? Diastole. I told you already. During Y descent, ventricle is in diastole. Rapid passive filling. During that time, blood is not moving outside, but blood is coming inside. What I told you. In tamponade, blood should move out for the blood should come. So during diastole, the ventricle cannot fill because the total cardiac volume is fixed. So there will be diminished what? Y descent. But these patients will retain X descent. Retain X, but there will be diminished Y. Why? Why they retain X descent? Because X descent is due to ventricular contraction. So what I told you, during ventricular contraction, blood is moving out. So that time, the heart can receive blood. Are you able to understand or not? So if you understand this one concept, that the total volume of the heart and pericardium is fixed in this condition, you will be able to answer. So blood can only come in when it is moving out. That's what is happening in tamponade. So that's why when the blood is moving out during systole, it can receive blood. X descent is normal. But during Y descent, where the ventricle is, where no blood is moving outside, blood is only trying to come inside, you are not able to receive blood. So that's why you have a diminished Y descent, but a normal or a preserved X descent. That's why we have very famous mnemonic, isn't it? Paytax. So you know this mnemonic? There's a mnemonic called Paytax. What is Paytax? So in a tamponade, there will be prominent X descent, but a diminished Y descent. Whereas in constitutive pericarditis, you will have a prominent Y descent. Yes or no? In a constitutive pericarditis, you will have a prominent Y descent, whereas in tamponade, you will have a prominent X descent. What is happening in constitutive pericarditis for that matters? What is the physiology behind constitutive pericarditis? I mean, constitutive pericarditis, 2 to 3 things you need to know. So one is prominent X plus there will be Y also, which will be retained. It's not a problem. Y also will be there in constitutive pericarditis. And second, you will see something called as Kussmaul sign. So what is Kussmaul sign in JVP? No, inspiratory fall in JVP is normal. Some books will say paradoxical increase in JVP during inspiration. That is Kussmaul sign, but not the case. If there is no change in JVP during inspiration, or alternatively, if the JVP increases with inspiration, this is called Kussmaul sign. I mean, these are, these things you can understand only if you study proper cardiology textbooks. Otherwise, it's not possible to understand because our local textbooks will give paradoxical increase in JVP with inspiration is called Kussmaul sign. Not at all. Even if JVP does not fall with inspiration, that is also called as Kussmaul sign only. Either no change in JVP during inspiration or a paradoxical fall in JVP during inspiration. Paradoxical rise in JVP during inspiration. Okay, I think in constitutive pericarditis, I already explained about why you have prominent Y descent. Didn't I explain? I explained, no? Because of the small end systolic volume, the amount that it can receive also will be less. And X descent will be normal. Maybe it may not be prominent, but X descent will be retained in constitutive pericarditis. There won't be any problem in the X descent also. Why? What is the reason for X descent? Ventricular contraction, which is okay here. And it can cause a normal X descent. There's nothing to do with the X descent here. X descent is normal. Y descent is also normal here. I mean, Y descent, in fact, will be more prominent. Here, an X descent will be retained in constitutive pericarditis also. But why there is no change during inspiration or the JVP is increasing during inspiration? One simple explanation that is given is in constitutive pericarditis, the rigid pericardium will not allow the pressure changes during inspiration, during respiration to get transmitted into the ventricles. That is the simple explanation that is given. Because there are a lot of other explanations. If I tell you, it will be unnecessarily complicating and it will be like confusing for you. So simple understanding is the rigid pericardium will isolate the heart and it will not allow the pressure changes within the thorax to communicate with the ventricle and the atrium. Do you understand? So that's why you don't get this pressure changes during the inspiration. So that is one important way to explain. So I'll show you one example of a Kussmaul sign. See this lady, only during inspiration, you can see JVP is rising. Now she is in expiration, now inspiration again. Expiration, inspiration again. Expiration, inspiration. Typical example. So you are able to see an increase in JVP during inspiration. That is Kussmaul sign of JVP. Okay. Okay, that's all. I think it's done. Almost all the important changes in the JVP has been done. So what are the least minimum things that you need to know? As far as abnormal JVP is concerned, prominent A wave, TS pulmonary hypertension, Canon A wave, SVT or AV dissociation due to complete heart block or ventricular tachycardia. Then large V wave, TR and probably constitutive pericarditis. You can see in CP also. So TR again. Then Kussmaul sign, constitutive pericarditis. Prominent Y descent, constitutive pericarditis. Prominent X descent, tamponade. Diminished Y descent, tamponade. And tricuspid stenosis. Okay. And one more thing I didn't tell is absent A wave. I mean, I told you already. Atrial fibrillation, absent A wave. That's all. That's the one thing I didn't say, but you can write if you want. Absent A wave is seen in atrial fibrillation. I think that completes our JVP discussion. That's all. You can go for break and come back. You can come back by maybe 6:55, 6:50 to 6:55. Okay. I think hopefully now you are able to understand the physiology better, at least to some extent, what hemodynamics is going on. Actually, it's quite important. If you don't know the hemodynamics properly, it's very difficult to get into why it's happening and What is the cause of all these things? So once you understood why it causes, it becomes very simple. And what to answer in exam, it's up to you.